This recording will cover part 2 of COPD. So with our patients with COPD, what are their priority problems? Number 1 would be decreased gas exchange. Other problems that they may experience include weight loss, anxiety, decreased endurance, and potential for infection. So let's look at some interventions for COPD. The goal is to have an SpO2 of at least 88%, be free from cyanosis, maintain cognitive orientation, coughs. The patient is able to cough and clear secretions effectively and maintain a respiratory rate appropriate for activity level. Airway maintenance is the most important focus of intervention for promoting to improve gas exchange. In terms of monitoring, monitor for a change in respiratory status in order to provide prompt interventions. Breathing techniques, so diaphragmatic or abdominal breathing and pursed lip breathing should be encouraged and taught to the patient. In terms of positioning, upright with the head of bed elevated is preferred for good oxygenation. The patient may also prefer a tripod position to ease breathing. Effective coughing, oxygen therapy. Again, patients with COPD need oxygen when they're hypoxic, and we have a goal for our COPD patients of 88 to 92%. We're going to talk about medications. There's medications that we can use in a minute. Exercise conditioning and pulmonary rehab. Exercise for conditioning and pulmonary rehabilitation can improve function and endurance in patients with COPD. Patients often respond to dyspnea from COPD by limiting their activity, even basic ADLs. Over time, the muscles used in breathing weaken, resulting in increased dyspnea with lower activity levels. Pulmonary rehabilitation involves education and exercise training to prevent muscle deconditioning. Suctioning can be performed when needed. Hydration is important to thin out those thick, tenacious secretions so that they're easier for the patient to cough up. And finally, vibratory positive expiratory pressure device. I believe sometimes they're called PEEPs. Your textbook has one that's called a flutter. But what they are, they're devices that when the patient inhales, it causes vibrations. And those vibrations actually loosen secretions and allows them to be coughed up more easily. Surgical management can include a lung transplantation, although that is rare. A lung reduction surgery can be performed to improve gas exchange by removing parts of the lung tissue that usually are hyperinflated. So they're the parts of the lungs that are filled with the stagnant air containing little, if any, oxygen. Post-op concerns would be monitoring for respiratory problems and usual post-op complications. Bronchodilator mucolytic therapies are maintained. Pulmonary hygiene would include incentive spirometry, CPT, which is chest physiotherapy. So a lot of times respiratory will have a vest that they'll put on the patient that'll sort of shake to help with loosening up any secretions, and also hourly pulmonary assessments. Other interventions include preventing weight loss. We want to encourage the patients to choose foods that are high in calorie and high in protein. Minimizing anxiety during acute dyspneic episodes is important. We want to encourage that pursed-lipped or diaphragmatic breathing. We want to refer the patient for counseling. Make sure we're instructing them about relaxation techniques. Let them know about other things they can do, such as hypnosis and biofeedback. And it is common for COPD patients to be on anti-anxiety drugs. In terms of improving endurance, we want to talk about energy conservation with the patient. Not listed there, but we could also include the pulmonary rehabilitation and using oxygen during periods of high energy use. In regards to preventing respiratory infection, watch for cues of respiratory infection. So the patient needs to know signs and symptoms of infection. We also want to promote immunizations for pneumonia and influenza and advise patients to avoid crowds, especially during flu season. So now let's take a look at medications used to treat COPD. Our number 1 listed here is our short-acting beta-2 adrenergic agonist, albuterol. Remember, albuterol works by opening up those airways, causing bronchodilation. Also listed as cholinergic antagonists. Our prototype is tiotropium. This is actually a dry powder inhale. So when we talk about med administration and the importance of knowing how to administer meds, this is one that we talk about because it actually has a little pill that you put in a capsule and it is able to release the powder in the capsule, and the patient inhales it. If you were to give the patient the capsule to swallow, they'd have no benefit from the medication. So again, tiotropium is a powdered inhaler. Another classification that you might see used are xanthines, such as theophylline. Corticosteroids we know are important because of their anti-inflammatory properties, and you know those end in -sone and -solone. Chromones can be prescribed. They can help reduce inflammation. Mucolytics, such as guaifenesin. Mucolytics, again, help loosen those secretions so they're able to be coughed up. A cough suppressant may be prescribed. Your prototype would be dextromethorphan. And the patient may get nebulizer treatments with normal saline or mucolytics, such as acetylcysteine or Dornase alpha. And finally, patient education. We want to promote smoking cessation, which is helping a patient stop smoking if they're a smoker. Make sure they understand their home oxygen, how to use it, how to take care of any equipment, how to know when it's becoming low. We want to help them out with obtaining any assistive devices for energy conservation if needed, whether it's bedside commodes, things of that sort. They need to understand their drug therapy, signs and symptoms of an infection. They need to be taught to avoid respiratory irritants. Nutrition therapy, maybe they need to be hooked up with a dietitian. They need to be told, that they still need to be active and maybe referred for some pulmonary rehabilitation. They need to avoid stressors and know what breathing techniques they can use when they're feeling dyspneic, that diaphragmatic breathing or pursed lip breathing. And basically any of the other interventions that we've already talked about, we want to make sure the patients are aware of them and that they understand them.